So we will see little bit about the operative hysteroscopy. In many situations, operative hysteroscopy may be one alternative of hysterectomy. Because if you are not doing operative hysteroscopy, then in many of the pathology, only option what you have is hysterectomy. But if you are very good in operative hysteroscopy, many causes of hysterectomy can be minimized, and just by operative hysteroscopy patient can be cured. Topographic anatomy already we know that most difficult part in the uterus to enter is the internals. Cervical canal diameter vary from 1.5 mm up to 9 mm. Then you have the cavity, then you have ostia, right and left ostia. Other things already you know, round ligament, fallopian tube, broad ligament, uterosacral ligament, uterine cavity, mesometrium, all you know, ureter, everything is visible. These are the endometrial anatomy. As we have discussed before, this is functional endometrium. It keep on changing during the cycle, and once it is shaded completely, then only 5th to 14th day is the best day to do the hysteroscopy. If you are doing in proliferative stage any of the hysteroscopic operative, be careful that dissection should only be done up to the internal longitudinal layer, and this is a line to stop. If you are too enthusiastic and digging the outer circular layer, you will enter into venous plexus and you may get a lot of bleeding. And to stop that bleeding, if you will increase the pressure, you are in more trouble. Anatomy of the uterus. Uterus is having 7 to 8 centimeter in the length, normal uterus, nulliparous uterus, 4 to 5 centimeter in the width, and thickness of the muscle is 2 to 3 centimeter. Weight is 50 to 80 gram. It has different ligaments, proper ovarian ligament, broad ligament, uterosacral ligament, McEnroe ligament, cervix, corpus and fundus. These are the 3 important parts. Most difficult part, most shrunken part is internals, and that need to be overcome. Many of the gynecologists, they prefer 0-degree telescope to enter into the uterus. They don't like 30-degree. Because 30-degree has a problem that it will show you the wall, it will not show you the black hole. Because 30-degree will show you 30-degree deviated. So, if you are seeing the black hole, that means you are going lateral. Even in laparoscopy, when you are performing, you might have noticed that while you are introducing the laparoscope in the cannula, it is showing you the wall of the cannula. It is not showing you the tip of the cannula. So that's why many gynecologists in hysteroscopy, to enter they use 0-degree telescope, so that entry will be safe and black hole will be, this is black hole, and this black hole will be in front, and then they slowly keep on entering under vision. And once they enter into the cavity, then they change 0-degree to 30-degree. How? Sheath will not be removed, sheath will be there, remove the telescope and change to 30-degree. Because 0 degree you can see all surrounding wall will be visible together with the black hole in the center. 30 degree always see on the side and then it enters like that. Because 30 degree is like a squint. Squint people, they are talking to someone and looking to you. You don't have any idea to whom he is talking. So same way, 30 degree will see like that and enter in front. So it's bad actually. And then slowly you will enter. In 0 degree telescope, once you will enter at the level of interloss, then in most of the normal uterus, you can see both the ostia together. This is the normal 3 to 10 millimeter. In the middle, it will be diameter of the cervical canal. And once you will enter at the level of interloss, with the 0 degree, both the ostia will be visible. With the 30 degree, both the ostia will never be visible. Because either you will see right or you will see left, you have to rotate to the other side to see other. So this is the ostia which is visible, and then you go other side. Now, if you have a 30 degree, then it is recommended that you should must do the bimanual examination to check that uterus is anteverted or retroverted. If it is anteverted, keep the light cable down. So it will show you up. Got my point? And if it is retroverted, keep the light cable up. If you don't have 0 degree. Otherwise you will perforate. So bimanual examination, PV examination, you put one of the finger in the posterior fornix, lift the uterus. Do you know there was one study performed in the John Hopkins? They did 200 cases examination of different age group of the female, bimanual examination like that, and they found that before the age of 35, 90% of the women, they have anteverted uterus. So this is 90%. And after that, slowly it started getting retroverted. This is retroverted. But retroversion is not a pathology, but your entry technique will different. That's why if you are doing hysteroscopy under laparoscopic guided, you have a lot of idea that where to enter. So, first surgery what we will like to see is the myomectomy. Operative hysteroscopy. This is how to enter, now myomectomy. As we know, myomas are different type, subserous myoma, intramural myoma, submucous myoma. If it is subserous, there is no role of hysteroscopy. If it is intramural, there is no role of hysteroscopy. If it is submucous and more than 4 centimeter with more than 50% intramural extension, then also there is no role of hysteroscopy. So, submucous myoma is of 3 types. Grade 0, that is predominantly pedunculated intracavitary. This is the best to remove by hysteroscopy. Then grade 1, more than 50% in the cavity, less than 50% in the muscle. This is also can be performed by hysteroscopy, but not in one single sitting. And if it is grade 2 with bigger 4 centimeter, then there is no role of hysteroscopy. Better always go for laparoscopy. Diagnosis, first you will put a diagnostic sheath. After that, you will start dissecting it out. You will use loop electrode, enter inside, And always you have to come dark to bright, means distal to proximal, and hook, look and cook. Always hook, look and cook. This is the ostia. This is the grade 0 predominantly pedunculated intracavitary myoma. This is diagnostic is over. You have seen all around. And now this is the electrode going, and you will go loop electrode and then touch, ting, and pull towards you. Activate small pieces at one time. Never be faster, never try to take a big chunk at one time, and start from the fundus lining and do de-roofing slowly. Once you started reaching near to the endometrial lining, then you have to compare the texture from the surrounding healthy endometrium. And once the texture of both become equal, this is the point to stop, because we know, see here, this is the texture and this texture is equal, that's all. Now you should never try to dig it, otherwise you will break the internal circular layer of the muscle and you will enter into venous plexus. It is not necessary to remove complete 100%. Even 90% of the myoma you have done de-roofing, remaining will degenerate automatically in subsequent cycle, it come out, and that's all, it's done. So it's a very easy surgery, especially if it is a small 2-3 centimeter myoma, and if it is predominantly intracavitary, you can do in only one sitting, it is possible to do. This is another case. Here also this is anterior wall myoma, and again resection is started. Remember, when you hold your resectoscope, CCD should never rotate, otherwise entire orientation, left hand is holding the CCD, and how to hold the CCD, that is the head of the camera. We have seen that cable should go with these 3 fingers, and it should be in between index finger and middle finger like that. And this resectoscope, when you are doing anterior wall, only the handle of the resectoscope has to be changed. Got my mind? If you will rotate everything, your orientation will be lost. Rotating the telescope is changing the field of vision. And rotating the head of the camera is changing the orientation. So head of the camera, these buttons of the head of the camera always should look at 12 o'clock position. Cable should look at 6 o'clock position, always in every surgery. Laparoscopy, cystoscopy, thoracoscopy, vitreoscopy, axilloscopy, retroperitoneoscopy, whatever. What only you are rotating is telescope. So for anterior wall, your resectoscope telescope will rotate like that. For posterior wall down, for lateral wall this, and is it okay? So this is important. And this is anterior wall, so CCD is same, and this electrode, and then slowly you will resect. Hook, look, and then cook. Never activate in open circuit, always come darker to brighter. And you will keep on resecting. Distal to proximal means darker to brighter. There is a separate learning curve of operative hysteroscopy. During diploma period, we have one practical for operative hysteroscopy where you will do this resection yourself. We have one model to do this resection. So this is slowly you will keep on cutting. If you see in the middle that you have little more tissue, you can use the stop, remove the inner sheath, outer sheath will never be touched, inner sheath working element, put Ehrlich evacuator, pump it and then again start. This is again hysteroscopic morcellator. This is a very popular instrument. Nowadays it is introduced. This morcellator can be introduced in the same outer sheath. Outer sheath, as you can see, it is already attached. And then you can enter and it morcellate. It is just like a shaver, how it shaves. It will keep on resecting the submucous myoma. This is hysteroscopic morcellator. Different tips are there. If it is fundus, you have a different tip. It is on the side, you have a different tip. Now, septate uterus. Septate uterus, as you know, it's one of the big problem, but you must be differentiating it with the biconjugate uterus as well as Asherman, adhesion. For that, MRI is important, because ultrasound may not separate the adhesion from the Asherman from the septate uterus. If we will do laparoscopy diagnostic together, septate uterus has one whitish band in the middle, and whereas biconjugate of course has a depression, and if there is adhesion, this whitish band will not be there, because septate uterus is a congenital abnormality. So it has a whitish band. After that, you will cut it. There are different ways of resecting it. You can have a straight knife as well as Collins knife. This is the straight knife which is resecting. You have to just cut in the middle. Here it is brighter, brighter means nearer, and both the side it is darker, that means deeper. Unfortunately, in septate uterus, you cannot come distal to proximal. You have to go proximal to distal. So you must be very carefully and very slow, not more than 3 millimeter in one go. Because if you will try that, I should take 1-2 centimeter from a small cavity, you will enter into large cavity. And your entire vision will be immediately lost, because suddenly fluid will go in the abdominal cavity, because in uterine cavity fluid is under tension, under pressure, 150 millimeter mercury. Now you can see this surrounding texture. As soon as this texture and this texture become equal, that means your work is done. So in hysteroscopy, texture gradient is one of the very important depth cue. Because shadow is not there, linear parallax is not there, motion parallax is not there, relative size is not there, aerial gradient is not there, only texture gradient is there. So, very careful, slowly you will cut and stop. After that, this side it is still little darker, this is little brighter, here is the ostia. So again slowly, millimeter by millimeter, you will cut and stop. And that's all. Only you have to cut it in the middle. In septate uterus, suppose this is the septa, you don't need to cut either side, only a split in the middle, that's all. It is already under tension, so it will go away. After that, put one IUCD and come out. So, this is a straight knife. Now we will see another video of the same septate uterus. Here we can see this is a whitish band in the middle, and this band is due to it is a diagnostic of the septate uterus. And you can see it is less flattened, more wider, isn't it? Because of this septa. At the end of the surgery, you will see this band will be no more. And this is laparoscopy, diagnostic laparoscopy is being performed. Uterus is fine, ovary is fine, uterocycle is good, IP ligament is good, fimbria is good. And now this is hysteroscopy. This is ostia. This is right ostia. This is right ostia. This is good. Left ostia was not clearly visible because it is small. Remember, in septate uterus, it may not be that both the compartment will be equal. One compartment may be small, another may be big. And this is septate. And now you have to split in the middle. And here Collins knife was used. Collins knife is better than a straight knife because you can rotate in either direction. Towards the cervix, it will be thin, of course. And once you go away from the cervix, it started becoming thicker because septate uterus is like that. Towards the cervix, thin. So towards the cervix, maybe in one go you can cut it. But once you go towards the fundus, you have to go in multiple steps. So this is Collins knife. It is just like our L hook. And you can see it is very thin near the cervix. And slowly hook, look and cook. Here also never activate in open circuit. First you hook, then you look and cook. Cutting current has to be used. 80 to 120 wattage current should be used. Here 40 watt will not work because we are working under fluid. Of course, wattage also depend upon the frequency of your generator, and slowly you will keep on. As you progress towards this fundus, you can see thickness increasing. And you should keep on comparing the texture of the surrounding wall. It is still dark, that means long way to go. Without texture, you cannot perform hysteroscopy. This is texture, and now you will compare. Sometime your friend who is keeping the laparoscope from above can show you trans illumination, and that trans illumination give you some idea about how much you have to still cover. So this is now becoming thicker, so you have to do stepwise, and you have to cut one step, second step, third step. Here, see this light. This light is laparoscope light. Laparoscope will be brought nearer, hysteroscopic light you have to decrease. And this red color will give you that your distance, it will give you, because red color has a property of giving you maximum attraction. That's why red absorbs light very fast. Red penetrates your eye very fast. That's why red is used as a danger sign all over world. For traffic, for railway, everywhere. So this will be trans-illuminating. Now we can see that surrounding wall started visible and it is too thick. So several steps you need to cut. And millimeter by millimeter, don't move much. Slowly you will cut because you are going proximal to distal. Again here you will wait and check the surrounding texture, and once you started seeing it is equal, then stop. Now we can see here right side is almost over, and wait, this texture becomes still, then almost right side is finished, just little bit, that's all. But left side of the septa wall is still there. So this is right, means patient right, your left is patient right, but this side is still darker. So this we have to still cut. And meanwhile, again ask the assistant to push the telescope and see the trans illumination. So that's why operative hysteroscopy, if you are doing under laparoscopy, it is always appreciated. Because you have added safety and you can find out if any complication happens and you can repair it also. If suppose accidentally we have perforated, take a bite and suture it by the laparoscope. That's all, there is no any problem, nothing happens, patient will not suffer. And suppose it is perforated, then never put IUCD, IUCD will migrate. So this is done. Now again you can see this is final diagnostic, now there is no band there. See, in the beginning of the surgery, see this band here. Did you see that? This whitish band. And more flattened here at the end, absolutely safe, and there is no band. And anteroposterior diameter increases. So this is called metroplasty. That is very rewarding surgery because open is bad. Hysteroscopic sterilization is also a very popular procedure, although it is less popular in India, and it is by Assure 2. Assure 2 has a device in which there is a metal that is called nitinol, and on the base you have this is silicon. So you have to introduce, it comes with the pusher, and it is an office procedure you can do easily in the OPD. So this is hysteroscope. It is already loaded on a pusher, and this is cervical canal, and now this is cavity. Here is the left ostia, and this is the right ostia. After that you will go nearer one of the ostia, and this is the guide wire. And this silicon part you will push into the tube, and nitinol part has to be leave dwelling in the cavity. So this is pushing the inside, and then pusher will be removed, and this is nitinol part. Pusher and guide wire will be pulled out. This is guide wire, this is pulled out, and now this will, just like a spring of a ball pen, it is like a coil. Nitinol is a metal which is mixture of nickel and titanium. That is called nitinol. It is not a separate metal. Once you mix nitinol, titanium and nickel, that is called nitinol. So this is done. After that, this is the nitinol part which is dwelling in the cavity. After that, another one you will push. This is a beautiful technique of sterilization. Only drawback is it is completely irreversible. It never can be reversed because it creates fibrosis of the proximal end of the tube. Another drawback is that up to 21 days you have to give the alternative method of contraception, because by the time it is fibrosis happen, patient may get pregnant, and ectopic also can happen. After 21 days, company is recommending that you should get one X-ray to make it sure that this metal will be visible in X-ray. So make it sure that it is at correct position, and then patient can, abstinence is not required. So this is hysteroscopic sterilization. Plasma sect and V sample. These are the two beautiful technology. Those are plasma kinetic, that is bipolar dissectoscope, which is very high frequency, around 1.5 megahertz, where it cuts under normal saline, and very high frequency gives you very good resection. Here we can see this is V sample. It is just like a twin blade which you use to shave. This is called plasma V sample. During dissection technique we have seen what is the difference between electrosurgery, radio frequency and plasma. So this is plasma, and you see it has a two electrode, and there is a spark in between two electrodes. Can you see that? It is a sparking, and due to that high frequency spark, tissue get evaporized, and then it cut. Plasma cut the tissue by evaporization, and it is bipolar, so you have to use the simple normal saline. You don't need glycine. So these are the advanced electrosurgical resection bipolar in the hysteroscopy which is possible. Now complication. Complication of hysteroscopy, trauma, intravasation, rarely death. Trauma happen, intestinal perforation, bladder perforation, rectal perforation, all can happen. Because even we perforate sometime in, in dilating the cervix also, isn't it? So you are putting and your dilator has gone into. So hysteroscopy, it is easy, you can perforate. Intravasation happen more if the patient has genital tuberculosis, hypoplastic uterus, and excessive pressure of installation. Means, suppose you have used, when we don't have, many people what they do, they don't have any measuring device. What they do, that they have a bottle and there is a needle with the pump and they push air into the bottle. You have seen that? In the bottle there is a big needle and that needle is attached with one pump and they push the air into the bottle. Which bottle? Saline bottle or glycine bottle. And that due to air, pressure is generated inside the bottle. It is cheapest device. It is dangerous because if the pressure increases 300 or 400 millimeter of mercury, then there may be death due to vasovagal shock also. And another problem is that suppose you are ignorant and fluid, थोड़ा सा वो जो ओटी में जाके राजा को बोलना कि फ्लूइड में पंप एयर पंप करने वाला जो हिस्टेरोस्कोपी का सेट है वो देगा और ग्लाइसिन का बॉटल भी लेके आएगा. So I will show you how they do. So this is bad. And sometime what happened, fluid is finished and then air enters. So you must have a Y channel and carefully someone should see the fluid, and if it is just about to finish, lock that channel and open other channel, so that air will not go. Hypoplastic uterus also is one of the reason intravasation can happen. And as we know, if glycine will create intravasation, hyponatremia will happen, distilled water will create intoxication. Glucose solution is good, that can be used. Many people, that's why they prefer glucose solution even for operative. Death happens due to two reasons. First is vasovagal shock, excessive pressure of installation, and another is embolism. Air embolism can happen. This is early. Late death is due to peritonitis. Means if you have perforated the bowel, first day, bowel is third B, so we will know third day. Perforation by the hysteroscopy will not be large, 4 or 5 centimeter. It will be couple of millimeter. So immediately first day you will not know. Second day you will not know. Third day all the feature of peritonitis will happen, and if it is not properly tackled, patient may get bacteremia, septicemia, and death can happen. So early death, vasovagal can be on table, embolism within hours, and peritonitis within days. So these are the complications. Now coming to contraindication. One of the contraindication is endometrial infection. If patient came to you, you are doing PV examination, patient has foul smelling discharge, fungal infection, bacterial infection, anaerobic infection, we should not do hysteroscopy because you are going to put all the infection in the blood stream if you are doing operative and in the peritoneal cavity if you are doing diagnostic. So first we should treat the patient for candidal infection or anaerobic infection or bacterial infection. Clindamycin, metronidazole combination vaginal cream should be given, antifungal also, and then you should start performing. Second contraindication is menstruation. Why menstruation should be contraindication? Yes, first is endometriosis may happen because these detached endometrial tissue can enter into the abdominal cavity. Second, more intravasation will be there because vessels are dilated and hyperemic. Third, very bad vision, nothing will be visible because red color is the biggest enemy of the laparoscopic surgeon. It absorbs all the light, nothing will be visible. And dark, nothing will be visible. So no diagnosis, no possibility. Infection also chances increases. Pregnancy is already a contraindication. But some cases, they do hysteroscopic fetoscopy also. Do you know that? Hysteroscopic fetoscopy also they do. And in that pregnancy will be there. Another indication of doing hysteroscopy in pregnancy is that sometime IUCD is there and patient get pregnant. Then by hysteroscopy you may remove IUCD without damaging the fetus. But of course you have to take a consent of abortion, it may happen. Although it is not necessary to remove IUCD, because in the book it is written that baby will come with the IUCD in the hand and tell to mother, what is this, what you did to me. But female are sometimes not comfortable that no, I don't want my baby and together IUCD. So please remove it. And then you can try to remove it without damaging the pregnancy. Another indication of pregnancy is heretiform mole with the pregnancy, where you can remove the heretiform without disturbing the pregnancy. But this is rare. So actually pregnancy is a contraindication. After that, pelvic irradiation is a contraindication. If your patient has received any pelvic irradiation due to any cancer, wall of the muscle has a fibrosis and it is necrotic. You do hysteroscopy, it will perforate the uterus. Cone biopsy or recent trauma is also a contraindication. Like recent trauma means someone has done MTP and then patient has missed abortion and you are thinking that you will do hysteroscopy, then always do under laparoscopic guided. Because suppose in this MTP she has perforated the uterus and now you do hysteroscopy, all your fluid will go inside the abdominal cavity and now you will be blamed that this is your complication, but actually it was not. Or patient has myomectomy done, laparoscopic, then up to 6 months you cannot do hysteroscopy, uterus will rupture. So any recent trauma is also contraindication. So this was regarding the operative hysteroscopy. Is there any question? For the, means your question is, once you are resecting the tissue, how you will remove in hysteroscopy? Do you know it is very easy? You don't have to remove the outer sheath, remove inner sheath and the working element and the telescope and attach the A-leak evacuator. A-leak evacuator has a pump and it has a filter inside. This filter, what it will do? It will put the fluid again back, but cut pieces will not go because it has a filter. So it is one-way filter. This is the A-leak evacuator. Can you see that? This is a pump. Iske andar there is a filter inside, and this filter, this you will attach to the outer sheath, and then you pump. And inside there is a filter. That filter here, this is a small filter. And this filter will not allow the pieces to go out and fluid will return back. So it will be a turbulence of the fluid inside. And that turbulence of the fluid inside will clean it. And this will also act for the this histopathology. the collected tissue, otherwise you don't have a tissue. And this will be acting as a histopathology. Suction is not required, it's already compressing. Suction, how much is the cavity capacity? Am I right? It is not abdominal cavity that as soon as you remove the pressure, automatically everything is ejected out. It wants to come out. You don't need to suck. So you can see here, what is this pump? This, what they do, that they pierce in the bottle. This is a 3 liter glycine. एक dextrose का bottle ले आओ ना. This is glycine you will use. 1.5% and 3% both is used. And this is Y channel. This Y channel is very important. At one time only one you will pierce and another clamp will be closed. This will be closed like that. But it will be introduced both together. And once it is about to, this is called Y channel. It has 2 channels. And one is about to finish, then you open another, this lock, and then you start. So this is Y channel. And this will be attached with your, in the needle. And this end will go to the hysteroscopic input channel. So this is, but this is very crude. But it gives you, here this is the pump also you can use. But it gives you very good pressure if you will push it inside. But the drawback, air embolism can happen and there is no measurement. So always use either Medex pump, Hysteromet, Endomet or Hysteroflator. This Medex pump, this is Medex pump. So this is very good and it can take 1 liter, 3 liter, it comes in different sizes of the bag. And it has a meter and it has a safety valve. So if anything happen, it will open. Any other question?
So do you give any routine antibiotics?
Antibiotic prophylactic should be given. Ceftriaxone, sulbactam, same way. Because all the infection, vaginal flora is already there. It should be cleaned also, betadine, painting, everything, because that all the infection inadvertently you may push inside the cavity.
Fibroid polyps.
Pardon?
There is a pathologies of submucosal fibroid polyps. Is it better to cut the pedicle?
In polyp you can cut the pedicle, even with the seizures also, cold seizures also, or with the Collins knife or hook. But in fibroid, pedicle will not be that much narrow. It will be couple of centimeter wider. It is not like a stalk. It will be quite wider and it is very vascular. If you directly try to cut with the scissors, it may bleed. And moreover, this cut fibroid will take many months to degenerate and come out. Am I right? Because 3 centimeter, how you will remove by the cervix? Isn't it? Resection once you are doing, it is cutting into small pieces and with the Ehrlich evacuator you can take it out. So fibroid, always try to de-roofing it and start from the apex and keep on going to the base. In polyp, directly you can go to the base. If you have a hysteroflator, then it has tube in and out both connected with your machine. So at the end of surgery, it will give you the idea that how much fluid deficit is there. But if you don't have this device, then you have to calculate by the measuring yourself. So fluid exit should be collected in a bucket. Always keep a bucket there so that whatever exit fluid is there is collected. And that way indirectly you can measure. But after some experience you will know that due to duration, that how much is inside, how much must have intravascular.